A very good morning, ladies and gentlemen. Welcome back to the second consecutive day of RESPIRE 13, the annual academic sessions organized by the Sri Lanka College of Pulmonologists. We have 6 different sessions lined up today, as usual, and we would like you to mute your mics during the presentations. And now let us begin with the 7th symposium of the academic sessions on sleep. I invite the chairpersons, consultant respiratory physician, Dr. Nandika Harishchandra, and consultant respiratory physician, Dr. Rishikeswaran, to introduce the speakers.
Good morning, everybody. Our symposium number 7 is sleep about. First speaker is Dr. Chandimani Ondugodage, consultant respiratory physician and senior lecturer, Department of Physiology, Faculty of Medical Science, and currently working at Isle of Wight and NHS Trust UK. She will start with obstructive sleep apnea, understanding the mechanics.
Thank you, Dr. Rishikeswaran, for that kind introduction, and thank you, Sri Lanka College of Pulmonologists, for inviting me to give this talk. Obstructive sleep apnea. We know cardinal features are snoring, with apneas resulting in frequent arousals. And we see that our patients mostly have daytime somnolence coming with witness apneas. And we have also seen that it is commonly seen in male gender, and we see as they grow older, you see more OSA, and in obesity, and also in those with high neck circumference. So those are the risk factors, common risk factors. But however, in clinical practice, we tend to notice that our patients do not always have these symptoms, that we see that they come with insomnia, and we also see a lot of female obstructive sleep apnea. We see comorbid OSA, those coming with MIs, atrial fibrillation, and so on, and also young, severe obstructive sleep apnea, and elderly OSA patients. So if you really look at obstructive sleep apnea, what is shown in blue, the clinical, this is what we really see. But if you think a little bit more, there's a lot of pathophysiology underneath, and also biological factors, and genetic factors, and also environmental and risk factors. So in order for us to treat these patients, we really have to understand the underlying mechanics of obstructive sleep apnea. So in order to understand the mechanics, the pathophysiology, I'm going to talk on 4 broad areas: the anatomical causes, impaired dilator muscle function, the high loop gain, and low respiratory arousal threshold. So in order to talk about the first one, we have to understand something called the critical closing pressure. Now, the critical closing pressure is the pressure at which the upper airway closes. So if you look at Starling's resistor model, you can see on one side we have the trachea, the pharynx, and the nose. The pressure at which the pharynx or the upper airway closes is called the critical closing pressure, or the peak crit. And this diagram is shows you have flow and pressure. And if you look at A, the green line, you can see there is nice flow. And along B, as the critical closing pressure increases, you can see that there is limited airflow. And in C, you can see that it is completely occluded. So which brings us to our upper airway. So you can have a stable upper airway where the airway is nicely open, or you can have a vulnerable upper airway where the airway tends to close, and also you can have highly collapsible upper airways. So if you take obstructive sleep apnea, you can think of things that promotes airway patency, and then things that promote airway collapse. So the pharyngeal dilator muscles, mainly the genioglossus, that actually promotes airway patency by keeping the upper airway open. And also lung volume. So when you take a deep breath, the lung expands, and there is longitudinal traction. That also keeps the upper airway open. Upper airway collapse, the negative pressure in inspiration. So when you're breathing in, there is negative intrathoracic pressure. that promotes upper airway collapse. And extraluminal positive pressure, that means outside the upper airway, any positive pressure will also promote upper airway collapse. So something like fat deposition and small mandible. So if you think about the peak rate, you can suspect those with a very high apnea-hypopnea index, more than about 40, or if you have to give CPAP pressure of more than about 80 for a patient, and patients in the polysomnogram, if you see predominantly obstructive events, then you can suspect that they have a high critical closing pressure. And similarly, low critical closing pressure in the opposites. So now that we understand about the critical closing pressure, let's look at the anatomical causes. So the first one, you can see this is the container-content theory. You have the bony enclosure and the soft tissue enclosure. So in a normal person, you have the airway, upper airways is nicely open. But in somebody with obesity, they have a lot of soft tissue. And then the bony enclosure is the same. So because of the soft tissue, there is reduction in airway size. And also if you have a small bony enclosure, like most of our Sri Lankan population, we have small faces, then you have, even with the same amount of soft tissue, you would have reduced airway size. So those are the anatomical causes. So if you look at this picture, you can see on diagram A, the green bit is the upper airway. It is nice and patent. But with obesity and also with age, you can see there is retropharyngeal tongue deposition, fat deposition. There is fat deposition around the uvula. Tongue is displaced. So there is reduced upper airway size. So if you look at the tonsillar size and tongue level, this is again something that we tend to look at in our patients. And then we use something called the Friedman staging system. Again, with that you can suspect whether there is reduced upper airway size. And also facial profile and malocclusion. So these things will also reduce upper airway size and promotes obstructive sleep apnea. So most of our treatment for OSAS at the moment is really more for anatomical obstruction. So we advise our patients to go for behavioral therapy like diet and exercise, weight loss, continuous positive airway pressure, again addressing the upper airway collapsibility, mandibular advancement devices, which we promote in patients with moderate obstructive sleep apnea, not in Sri Lanka though, and also pharyngoplasties, which is done by the ENT surgeons, again to address upper airways, and maxillomandibular advancement and bariatric surgery. So these are the things that we really use to manage obstructive sleep apnea, and that is to manage the anatomical treatment. So not all our patients respond to these treatment. So this is what brings us to the other reasons, other underlying causes for obstructive sleep apnea. So one is impaired pharyngeal dilator muscle. So let's look at, revise our anatomy, look at the upper airway dilator muscles. So you have genioglossus, that is the one that keeps your tongue in place, tensor palatii, geniohyoid, sternohyoid, and all the pharyngeal musculature. So these are the muscles that keep the upper airway open during breathing and reducing the peak rate. So therefore, the upper airway stays open. Now, if you look at sleep, you can divide it into two, non-REM sleep, which consists about 80%, and REM sleep, which consists about 20%. So we know in non-REM sleep, there is reduced sympathetic nerve activity, the heart rate and the blood pressure drops, so what we call nocturnal dipping. Breathing pattern is regular, reduced cerebral blood flow, reduced minute ventilation, and reduced muscle tone. In REM sleep, the sympathetic activity is similar to wake. Irregular breathing pattern, increased cerebral blood flow, and the breathing is mainly dependent on the diaphragm. This is something that we quite see in our patients, and absent muscle tone. So if you look at this graph, you can see the first one is the EEG activity, and you have the airflow, and you have the EMG activity, which shows our muscle, And so if you look at the airflow, you can see the patient is having an apnea. There is an obstructive apnea. And during that time, you can see that there is an arousal, and you can see the EMG activity. There is reduction in the effort, and then there is an increase in effort. So which brings us to the airway muscle complex interactions. So if you look at the upper airway muscles, so there are various things that can happen over a period of time. For example, there can be vibratory trauma, mucosal injury, stretching and laxity, altered muscle recruitment, low tone, muscle degeneration. All these put together, there is reduction in muscle activity of the upper airway muscles, which makes our upper airway muscles lax. And there is poor muscle responsiveness, increases the peak rate, and then promotes obstructive sleep apnea. So in this group of patients, so what are the potential therapies? So the potential therapies should really be aimed at to improve muscle responsiveness. So like there's pharmacotherapy, muscle training, myofunctional exercises. There's a lot of interesting studies on this muscle training. And the muscle stimulation. So the muscle stimulation, hypoglossal nerve stimulation, things like that can improve the muscle tone and keeps the upper airway open. Then the next one is high loop gain. So what is loop gain? So loop gain is really our ventilatory response to our ventilatory disturbance. So how, if there is a ventilatory disturbance like an apnea or reduction in airway, how does the ventilatory response happens? So if you look at this graph, you can see you have there is airflow. Then you have the required breathing level is shown with the dotted line, and then there is a ventilatory disturbance. So that means there is some cessation of airflow. So, but look at the ventilatory response. There is an inappropriate ventilatory response following that ventilatory disturbance. So this is what we call loop gain, high loop gain. So these patients with high loop gain, these patients, when you look at their polysomnography, you can see that they have a lot of mixed and central events. I mean, those who regularly see PSGs would know some of our patients, they have a lot of central sleep apneas, they have a lot of mixed sleep apneas. So these are the patients with this breathing instability. And they also have Cheyne-Stokes respiration during sleep. Now, this is because when you have high loop gain, you have inappropriate ventilatory response. What happens is when you hyperventilate, obviously your carbon dioxide will drop. The moment your carbon dioxide drops, your chemoreceptors are no longer sensitive, no longer stimulated, so you tend to have an apnea. So you see this Cheyne-Stokes pattern of breathing. And then these patients have more non-REM related events. Now we looked at what happens in REM and what happens in non-REM. So if you look at your PSG, and then, these are the kind of patients that you find that you put them on CPAP, they are not really working. And if you look at your PSG and if you see that they have more non-REM related events, they have more mixed patterns, then you have to suspect whether they have underlying loop gain, breathing instability. So these patients, mandibular advancement devices, hypoglossal nerve stimulation, things like that don't really work. So potential therapies are, one potential therapy is acetazolamide and oxygen therapy. So acetazolamide is a diuretic, which is a carbonic anhydrase inhibitor. So when you use that, there is a tendency to have a little bit of acidosis, which goes on stimulating the chemoreceptors. So that is the basis of that. Then the last one, low respiratory arousal threshold. So what happens in obstructive sleep apnea? When you have an apnea, certain patients, they have a awakening or an arousal. This can be a complete awakening or just an arousal. And when you have lots of arousals, they tend to have excessive daytime somnolence. So this one shows, EEG shows, is in the top line, and you can see there epiglottic pressures. As the epiglottic pressures drop, that triggers an arousal. So if you have a low arousal threshold, that means even as a lower epiglottic pressure, as long as the epiglottic pressure starts to drop, they can get an arousal. So what are the potential therapies? So these patients, we see them, they are very sleepy. They don't have such a high AHI, but you find that they are quite sleepy. And you try them with various things, but it doesn't really work. So these patients, the potential therapies would be use of a hypnotic, because we want to dull that arousal, so they would get better sleep. So in a nutshell, if you look at obstructive sleep apnea, you have repetitive upper airway obstruction during sleep. And anatomical causes, impaired anatomy and narrow collapsible upper airway is the commonest. But you can have impaired upper dilator function, which we talked about, low respiratory arousal threshold, and unstable ventilatory control. So you don't have 4 categories of patients. There is an overlap of all of these categories. So if you have a patient who is unresponsive to your treatment, think whether these things are there. So looking at their PSG would also be very helpful. So I have just summarized in this one the 4 endotypes that I talked about, and then the potential therapy. So we are generally targeting the anatomical obstruction with CPAP, mandibular advancement devices, upper airway surgery, bariatric surgery, and behavioral therapy. Those with more impaired pharyngeal dilator muscle would improve with pharmacotherapy, muscle training, and muscle stimulation. So, and then those with high loop gain, there is a potential for acetazolamide or supplementary oxygen, and those with low respiratory arousal threshold, the use of hypnotics. So this is where I work in the winter, where the duck pond has actually frozen, and that particular morning I couldn't capture that, but all the ducks were walking on water instead of swimming, so I wanted to share that with you. So thank you very much.
Thank you, Dr. Chandimani. So now we are moving from the anatomy, physiology, and mechanics. Interesting topic, sleep physiology. Our speaker is an international speaker, Prof. Jason Ellis from UK. He is a professor of sleep science, director, Northumbria Sleep Research, Department of Psychology, Northumbria University. Over to you.
Welcome, everybody. I am Professor Jason Ellis, and I'm going to talk to you today about some recent innovations in sleep psychology. I do have some conflicts of interests. Please feel free to read at your own leisure. What we're really going to talk about today is 2 advances in our understanding of the psychological aspects of sleep and sleep psychology in our understanding of sleep disorders. The first theory that we're really going to talk about here is called the mind after midnight hypothesis. And this was very recently published by Tubbs and colleagues. So what do we mean by the mind after midnight hypothesis? In essence, if we think about its most basic premise, it is a bad thing to be awake when reason sleeps. And that's a quote from Dr. Michael Perlis from the University of Pennsylvania. But what do we mean by this? If we really look into it, what we've discovered over the last few years is that during the night, there is a very large tendency for bad things to happen, specifically between the hours of midnight and 6 a.m. If that individual happens to be awake, we know that there are relationships between being awake during that period and interpersonal violence, general violence, substance misuse, suicide and self-harm, and increased food intake. And so one of the real questions is why is it that this period of time during the night between 12 and 6, individuals are more prone to taking part in much more risky behaviors. The reason really, and I'm going to unpack this somewhat, is a combination of the natural nocturnal variations in our circadian system, in other words, our biological clock, and the sleep loss that actually is occurring because somebody happens to be awake. And these are really influencing multiple systems within the individual. Executive cognitive systems feed into an overactive amygdala, which is the emotional center of the brain, resulting in an aberrant reward system. And of course, as an outcome, negative health behaviors, or indeed violence. So let's talk about this. In order to understand this concept much more clearly, it's worth understanding that there are 4 main principles of normal sleep at night. What we know is that the sleep system, the homeostatic system, and the circadian system work in tandem during the night, really to restore synaptic functioning. In other words, they're trying to keep our brains healthy after quite a lot of work during the day. The way that they do that is by reducing excitability. In other words, in order to fix the brain, we need to keep it offline somewhat. And so we reduce excitability within our synaptic systems. The second thing we have to be mindful of is that dopamine, which is a hormone that's largely related to reward processing, does tend to have a big peak in the early hours of the morning. It is an internal indication that we are getting ready to wake up in the morning. And so it is a big surge in the early hours of the morning, which is allowing us to start getting ready to start our day. The third thing that we should be mindful of here is that our affect system, our emotional system, is actually very, very circadianly driven. And what do we mean by that? In the first part of the night, generally people's mood would be quite positive. It carries right the way through the daytime, where you have a positive affect, to the first few hours of the night. However, in the second part of the night, in the early hours of the morning, what we tend to see is that our affective system is in a very negative space. This is largely, as I said earlier, regulated by the amygdala, so it doesn't tend to bleed into the daytime. The final thing to remember about normal sleep is that our reward system and our executive cognitive functioning systems tend to also go offline during the early parts of the night through to the early parts of the morning. This is important because we need to fix and repair the body during the night. And so it actually makes no sense for us to have short-term memory, reasoning, attention, perception. Those are daytime activities. And so those systems go offline during the night, just to allow us to repair and fix the system. So you've got those 4 elements which are really helping us regulate our emotional and psychological health right the way through the night. So what does the mind after midnight hypothesis suggest? Well, if we think about those circadian processes, so in other words, those ones that are down-regulating synaptic function, the dopamine that comes in the early hours of the morning, and the affective system, even though the individual may well be awake, those systems are still doing their job. So they're still regulating dopamine, reducing synaptic activity, and of course, managing our negative affect. However, if we happen to be awake during that time, synaptic activity cannot re-regulate. So what do we mean by this? In essence, the mind at night is there to help process, manage, problem solve. And in order to do that, it has to go through a lot of processes of switching things off, which might affect the ability to manage our minds. If we're awake, those things are still switched off, and the hormones that help us regulate that are still switched on. What does that lead to? You've got sleep deprivation because somebody is awake during the night. But more importantly, what we tend to see is that people will have a narrowed attention focus. So in other words, they become quite consumed with a small number of things if they're awake during the night. And these things will tend to focus on negative stimuli. Add to the fact that we've got challenges within our reward system because those parts of the brain are actually not being active at that time. Therefore, our reward system tends to elevate and become quite excitable. That can lead us into poor decision-making processes. The final thing is, of course, because the circadian system is aligned with negative affect, well, then we could have this negative self-referential behavior. In other words, you start to think badly about what's going on. If you think about those three things happening, our reward inhibition is down, we're negatively affected, and we don't process information in a rational way. This can then lead to those negative outcomes that we were talking about. So really it is about being awake when your executive system and your cognitive system is actually asleep. This is what really does give us that indication that being awake in the night is a very, very bad thing to happen. I suppose the question is what does this mean to us? When we're seeing patients, what does it mean? It's likely that your patients, if they are having sleep problems, they are going to have a very poor mood associated with that. They're also going to have those attentional biases. They can't stop thinking about sleep. And so in terms of sleep disorders, it's also really important to look at affect, anxiety, depression, and stress. What we need to do is try to determine ways in which we can help manage the midnight mind, especially in our vulnerable populations, such as those people who are already anxious or depressed. The second theory we're going to talk about is Spielman. Now, Spielman created a model of the pathophysiology of sleep disorders, specifically with insomnia. In essence, what Spielman says is that we have predisposing factors which make some of us a little bit more vulnerable to insomnia than others. They're not enough to give us insomnia, but they change our vulnerability. What happens in terms of the pathophysiology of insomnia is we have a precipitating event. In other words, something triggers the insomnia. That could be something cardiovascular or other health related. It could be a psychiatric problem or indeed a stressful life event. That pushes us over the threshold into getting insomnia. Now, that is actually a normal biological reaction to stress. However, in the early parts of insomnia, Spielman starts to talk about perpetuating factors. And these are ways in which we try to compensate for our sleep problem. We might want to go to bed earlier, we might want to lie in, have a nap, drink coffee to keep us awake, or indeed drink alcohol to put us to sleep. As we can see from Spielman's model, what tends to happen is that after a period of time, about 3 months, it's not the predisposing factors that really give somebody the insomnia. They don't drive the insomnia anymore. It's not those precipitating events. The biological sequelae of those events has indeed diminished. What Spielman says is these perpetuating factors are the things that keep insomnia going, and they're the ones that keep it alive and maintain it. So they're the ones that really are the focus of our chronic sleep condition. This has led us over the years to talk about how we manage that. And one of the main ways we do that is through something called cognitive behavioral therapy for insomnia, CBTI. The premise of CBTI really is to try to manage those particular perpetuating factors, because if you can imagine from the diagram here, if we knocked off the blue block, the individual would not have insomnia any longer. Now, although this theory has been around for quite a while, since the early 80s, it never has been formally tested until recently. And this is where we're talking about a new innovation in sleep psychology. And this is work done by myself and my colleagues in Northumbria, which is in the United Kingdom, as well as my colleagues in the University of Pennsylvania. What we've done in this instance is we've actually looked at the pathophysiology of this insomnia. Is it the case that we have these predisposing, precipitating, and perpetuating factors? And in terms of those perpetuating factors, which ones are those that actually relate to somebody developing the insomnia? What we've determined is that actually, yes, people do need a stressor in order to give them that level of insomnia. So insomnia needs to have a stressor in order to set somebody on that pathway. This is influenced by those predisposing factors that we talked about, very specifically your stress reactivity. The more stress reactive somebody is, the more likely it is that when they are faced with stress, they will lose sleep as a result. But what else have we determined from this program of work? Very interestingly, and although we talk about sleep extension as being one of those issues around perpetuating insomnia, in other words, going to bed early, lying in, it actually doesn't appear to relate to the progression from acute to chronic insomnia. It's more a case that those people, when they do have insomnia in the first instance, they still stay in bed. So they still keep the same rhythm that they had before they had the sleep problem. It's a failure to self-sleep restrict, not the fact that they're actually spending more time in bed. That can help us therapeutically in terms of understanding where we should target treatments. What was the most interesting thing is that sleep preoccupation, it's those affective elements around sleep, they're the ones that drive insomnia. And it sort of also speaks to the mind after midnight hypothesis, because those nighttime thoughts are going to then translate into the daytime. It is the level of somebody's preoccupation with their sleep that drives them into that framework of chronic insomnia. Levels of depression and having a previous episode of insomnia also feed into that dimension. Again, another really interesting fact is that from this data, what we've determined is that that sleep reactivity, when you're stressed, you stop sleeping, actually increases the odds of you developing acute insomnia and going on to chronic insomnia by about 76%. And so if we want to target that particular pathophysiology, in other words, we want to stop insomnia from happening, we have to manage stress reactivity. So what does this mean to us as specialists? We might want to think about the timing of that transition from acute to chronic insomnia in relation to DSM-5 criteria. There may be more of an arbitrary dimension between acute and chronic insomnia. They certainly seem to have a lot more perpetuation than we would previously thought during that acute phase. Is sleep restriction necessary for CBTI? It is one of the foundations of cognitive behavioral therapy for insomnia, but we now question whether that may actually be the case, or whether during the acute phase we could actually just give somebody a little bit of sleep restriction at that point to circumvent the system. We talk about science in terms of this is our findings, but of course there are going to be individual differences. And certainly we can see that some individual differences feed into people's perpetuation of their sleep problems. But it does overall give us a real good avenue to start talking about preventative sleep medicine. It gives us that way of working and that way of moving forward where we can actually prevent people from developing sleep problems like insomnia in the very first instance. I don't do all of my work on my own, naturally, so I always like to thank all of my collaborators, the team at Northumbria, and of course all my collaborators around the world. Thank you very much.
Thank you, Prof. Jason Ellis. Now we are going to see another aspect of sleep and insomnia. It's from the overseas speaker, Dr. Carol Huang. She is the Senior Staff Specialist, Respiratory and Sleep Medicine, Obesity Management Service, Canberra Health Services, and Clinical Senior Lecturer, Australian National University, and she is my trainer during my overseas training. So she is going to talk about comorbid insomnia and sleep apnea. Over to you, Carol.
Thank you. My name is Carol Huang, and I'm the Director of Respiratory and Sleep Medicine at the Canberra Hospital. And I want to thank the organizers for inviting me to speak to you today. And my topic is COMISA, also known as comorbid insomnia and sleep apnea. So I thought that before we get into the topic, let's start with a case history or case study. And my patient is called MD, and he's a 40-year-old male who came to our clinic complaining of 6 years of difficulty sleeping since the birth of his second child. His entire family, including both children and his wife, sleeps in the same room, and they all go to bed at 9:30. MD wakes up at 2 a.m. and finds he's unable to fall asleep again, and he's quite distressed about this. He complains of poor concentration and irritable mood during the day. MD came with a type 2 sleep study, which was performed 2 years prior to the current presentation, and this showed severe obstructive sleep apnea with an apnea-hypopnea index of 58.6 per hour and this was all done without seeing a sleep physician. MD at that time then tried to acclimatize to CPAP through a private vendor without much success. He works as an Uber driver, and he denies any sleepiness while driving, and he also denies microsleeps or motor vehicle accidents. His Epworth sleepiness scale is 0 out of 24, and he tells me he only drives during the morning and the evening peak hour. He doesn't drive at night at all. His only other medical history is that of hypertension and hypercholesterolemia. On examination, MD weighed 83 kilograms, and he is in the overweight range with a body mass index of 29.6. He has a severe oropharyngeal narrowing, and his modified Mallampati score is 4. So the question I have for you is, what would you do at this stage? And here are a number of options. A, MD has OSA and needs to start CPAP as soon as possible. B, MD needs a sleep study, as the previous sleep study was done 2 years ago and may not apply to his current symptoms. C, MD needs education about sleep hygiene. D, MD needs treatment for insomnia with a hypnotic medication. E, MD will benefit from completing a sleep diary to assess his sleep patterns. And F, MD should stop working as an Uber driver. So what do you think here? So let's get into this topic and talk a little bit about obstructive sleep apnea. I don't need to tell this audience that obstructive sleep apnea is a syndrome that's characterized by frequent collapse and narrowing of the upper airway during the sleep, which results in oxygen desaturation, changes in sympathetic activity, and sleep disruption. And this leads to a number of symptoms, both at night and during the day. And it is known to result in substantial societal costs through healthcare utilization, reduced quality of life, and reduced workplace productivity. Insomnia, on the other hand, is largely sort of associated with self-reported symptoms and impairments, and it is by far the most common sleep disorder that presents to primary care. And it is characterized by nocturnal symptoms of difficulty either in initiating or maintaining sleep or undesired early morning awakenings. And in the daytime, these patients present with fatigue, concentration difficulties, lethargy, poor mood, difficulty with workplace productivity, and increased effort to perform daytime activities. So what is COMISA? COMISA is essentially when insomnia and obstructive sleep apnea co-occur in the same person. And it is not a new condition. This was first recognized in 1973. And COMISA itself shows not only the shared features of both obstructive sleep apnea and insomnia, they also show features that are unique to insomnia, such as difficulty initiating sleep, long awakenings, and conditioned relationships between the bedroom environment or routine with arousal and alertness, and usually associated with some dysfunctional sleep-related beliefs and attitudes. Whereas obstructive sleep apnea symptoms are also evident in COMISA with upper airway narrowing and collapse during sleep, resulting in snoring, choking, and gasping for air. And these patients often present with morning headaches. So how common is COMISA? This condition actually appears to be fairly common, although the prevalence differs depending on the clinical setting, the sampling methods, and measures, as well as specific criteria applied to define each condition. It is thought that 30 to 40% of patients with insomnia have comorbid OSA, and conversely, 30 to 50% of patients with OSA report comorbid insomnia. And why is this important? The COMISA patients actually have greater morbidity, and the diagnostic process as well as treatment decisions for conditions are much more complex. And adjunct treatment and assessment for insomnia in patients with OSA can lead to improved sleep, mental health, quality of life, and adherence to OSA therapy. And therefore, identification of patients with COMISA and management is actually quite important in clinical settings. So the characteristics of COMISA is that these are actually potentially associated with increased risk of cardiovascular disease and all-cause mortality. If you look at the paper published by the chat and ERJ in 2021, where they looked at the data from the sleep heart health study, the hazard ratio is increased over 15 years of follow-up in those with COMISA compared to those with nada insomnia or sleep apnea. And Sweetman in 2022 also published a paper based on NHANES 2005 to 2008 data, and again showing an increase in all-cause mortality compared with those with nada insomnia or sleep apnea over 11 years. So is the condition truly comorbid, or is this a secondary insomnia? Now, the reason we think that this is a comorbid condition is that COMISA patients respond to targeted insomnia treatment. And these patients will have insomnia persistently if you only treat them for OSA alone, and insomnia improves the overall management of COMISA. And therefore, these are true conditions that coexist with each other. And if you're looking to assess patients with insomnia symptoms, then there are a few approaches that are available. One could use a simple self-reported tools such as insomnia severity index or sleep condition indicator. But it's important to remember that both insomnia and obstructive sleep apnea have similar daytime symptoms. And therefore, it is important to specifically focus on presence of nocturnal insomnia symptoms rather than just looking at the total insomnia scores, because a lot of those may reflect the shared features of both insomnia and obstructive sleep apnea. And sometimes using a 1 week self-reported sleep diary can also be useful. And the management approaches for COMISA includes that we need to treat both obstructive sleep apnea and insomnia, because insomnia reduces PEP adherence and leads to high rates of immediate rejection and poor nightly usage over time. And this has been known for quite some time and was mentioned in the AASM Task Force guidelines back in 2009. Those patients who have a confirmed or suspected obstructive sleep apnea should be screened for insomnia symptoms, and patients who are reporting insomnia should also be assessed for OSA risk. And treatment for both OSA and insomnia should be made available for patients with COMISA. So it is important to remember that the most effective treatment for insomnia is CBTI. And CBTI includes a range of elements which I have shown here. It includes education about sleep, it includes stimulus control therapy, bedtime restriction therapy, cognitive therapy, as well as relaxation therapy. And you can see all the different elements of it in this slide. Now, it is important to remember that it's the whole package that's actually being shown to actually work in insomnia, and just having a sleep hygiene information as a standalone treatment is not adequate. And it contains elements that also educate patients about myths and misconceptions of sleep. What about pharmacotherapy for insomnia? Sedative hypnotics such as the Z drugs, so that's zolpidem or zolpiclone, or benzodiazepines are the most common approach to manage insomnia. These are not recommended as a first line or long-term management approach due to potential for dependence, side effects, and tolerance to therapeutic dose. And certain medications exacerbate obstructive sleep apnea in some patients. However, sedative hypnotics may be useful in the subgroup of patients who have a low respiratory arousal threshold phenotype. So with MD, what did we do? We gave him some sleep hygiene advice on his first consultation, and we suggested that maybe he would like to consider using slow release melatonin at nighttime, and perhaps also use early morning sunlight exposure to actually strengthen his circadian rhythm. We also suggested that he should get out of bed if he's unable to fall asleep after nocturnal awakening, and only goes back to bed when he's sleepy. And as he is an occupational driver, we wanted to institute CPAP as soon as we possibly can. And we suggested to his primary care physician to refer him for CBTI. So MD came back after a week, And he complained that PEP use is actually contributing to his insomnia. He had issues with dry mouth. He used the device for 5 hours and 30 minutes per night. And we can see on his automatic titrating CPAP, that the 95th percentile pressure is about 10.2 centimeters water. The AHI is 0.5 per hour, but the patient says this is ineffective. And so we spent some time working with him and decided to increase the ramp time and also increase the humidity on his humidifier. We ordered a diagnostic sleep study to confirm the obstructive sleep apnea because the patient was adamant that the previous diagnostic sleep study is wrong. And at the same time, we asked him to complete a sleep diary. So this took a couple of weeks and he came back at week 3. And his sleep study results is available at this stage. And this, in fact, demonstrated he has moderate obstructive sleep apnea with an apnea-hypopnea index of 28.5 per hour. And in fact, on the study night, he had 362 minutes of total sleep time. But the patient actually reported that he had a little sleep during the study night. At this stage, he's still using CPAP or APAP, and the usage is 3 hours and 59 minutes per night. And the 95th percentile pressure is 9.9 centimeters water. So at this stage, we diagnosed paradoxical insomnia, or perhaps sleep misperception will be its other name. And we changed him to fixed pressure CPAP at 10 centimeters water. And MD was having some issues with finances. So we suggested that he should consider CBTI through a university-led clinic at our local university psychology clinic. So MD came back to the clinic in week 6. And by now he's using CPAP therapy for 10 centimeters water. And his average usage is now 4 hours and 8 minutes. It's not great, but it's adequate for him to receive a government-funded CPAP device and to drive. And we didn't see him for a while. He came back again at about the 6 months mark, and by now he reports a significant improvement in his sleep quality, but he still complains of early morning awakenings and having racing thoughts and unable to fall asleep at night. He tells me that he's having daytime naps, and he's using CPAP during his daytime naps. And we spent some time discussing again about attending CBTI. His CPAP usage by this stage has increased to 7 hours and 58 minutes per night, with 100% of the nights using the device for over 4 hours, and he continues to drive for Uber. So that's the end of my presentation, and the summary from this presentation is that commissar is incredibly common. 30 to 50% of patients with OSA in the sleep clinical cohort report comorbid insomnia symptoms. And these patients have worse sleep, mental health, physical health, and quality of life compared with those with other OSA or insomnia alone. And patients who have commissar uses PEP therapy for fewer hours per night, and that CBTI is recommended as a first-line therapy for insomnia. And CBTI is effective insomnia treatment in the presence of untreated OSA. And for those of you who run a sleep clinic, this should incorporate insomnia assessment tools and evidence-based insomnia treatment and referral pathways to provide a personalized care for patients with commissar. Thank you. And if there are any questions, we can talk about them at the Q&A session.
Thank you, Carol. It's a very informative talk about sleep comorbid insomnia. We are now moving to the next lecture. It's setting up virtual sleep clinic. It's delivered by Dr. Tracy Jones. Tracy Jones, MSc Advanced Clinical Practice, Lead Clinical Respiratory and Sleep Physiologist, Respiratory Department, St. Mary's Hospital, Newport, Isle of Wight. Over to you, Tracy.
Hello there, good morning. I'm coming from the Isle of Wight this morning and it's actually 3 a.m. here, so it's the early hours of the morning. So bear with me because I've had some issues with technology, but we'll battle on. So I've come today to talk about the use of telemedicine in CPAP patients, and this coincides with a piece of research that took place on the Isle of Wight over the last 2 years, looking at how effective telemedicine is in compliance on our CPAP patients and whether it has a place in our patient pathway. So this is the Isle of Wight. We're a really small island in the English Channel between France and the UK. Generally, it tends to be a bit warmer down here than the rest of the UK, and we have a really small population of just under 150,000 patients. The average age on the island is a little bit older. Lots of people come here to retire, and we tend to have a population in the kind of 50s upwards, and those are the sorts of patients we normally see. Most of our people on the island are over the age of 18, so we have not so many young people here, and most of them speak English. 1 in 6 of the UK on the island, in the UK, tend to be over the age of 65. However, this is higher on the Isle of Wight at a rate of 28%. And because of that older population, we tend to see quite a large group with OSA. And also on the island, we do have an obesity issue with over 66% of our adults coming in as overweight or obese, which also drives the number of patients that we see with sleep apnea. So this is where I work, this is St Mary's Hospital. We are a 246-bedded hospital with operating rooms, a helipad and A&E, and all the usual outpatient services that you would see in any large hospital in the UK. And it's quite unique in that we have quite a lot of services that we manage as physiologists, which is very unique for the UK, and therefore our patients tend to see us for their diagnostic tests and they go on for treatment and follow-ups. So they get to know us over many years. So this is our team. They are so delighted to have a picture in here. So we're a really small team of physiologists. We have a number of students that we're slowly training through the system, and we're growing with time. And that's mainly because of the increase in patients that we are seeing diagnosed with sleep apnea or being referred for sleep studies. So these are the services that we currently offer within our unit, which, as I said, is quite unusual for a population of 150,000. But because of the stretch of water between us and the UK, we do have to offer every single diagnostic test. So we offer a full range of respiratory services, but we also offer sleep within our department. Currently, we perform cardiorespiratory sleep studies at home, but we are looking at developing a PSG service as this has become available due to extra funding through the government. We also offer CPAP, non-invasive ventilation, and ventilation. So we've got a full range of services that we're offering through our small team. So this research came about because technology is kind of seeping into CPAP patients and their treatment. Up until probably about 10 years ago, we didn't see so many modems, online apps for these people. It's been commonly used in other diagnostics and other mortalities such as diabetes for a long time, but it's really only just come into CPAP use in the latter years. What we wanted to know was, compliance is really difficult in these patients, but is there something else that we could be doing that would improve their outcomes, such as supporting them virtually, offering virtual appointments, having health apps that they can monitor their own treatments and make decisions about their own CPAP use. So the question was, could technology improve patient compliance? And if it could, should this be something we should offer as standard with our patients? As currently everybody comes to us face-to-face, has their yearly appointments with a clinician. And we just wondered if there was a different way of doing things. Unfortunately, we started this research and then COVID-19 hit. And This was a difficult time for everybody, including the UK. Most of the outpatient services shut down temporarily. We weren't able to offer a lot of our tests because they were considered aerosol generating. So the world kind of really changed very quickly. However, this also offered an opportunity. If we can't get our patients into us, what else can we do? What can we offer them? Can we offer them a virtual platform that still maintains their treatment, maintains their follow-up appointments, and make sure these patients stay well and out of hospital? So even though this kind of slowed things down for a little bit, actually it did offer a massive opportunity to relook at how we offered our services and whether we could be a little bit more flexible in how we see our patients. So the aim of the study that I put together was to look at standard care, which we consider as a face-to-face appointment with us, and all of your follow-up appointments being face-to-face, when compared to using technology. So the two bits of technology we decided to look at was the first one was a modem. So that was to offer the opportunity to transmit the patient data to us and then follow them up virtually. This didn't, however, allow the patient any access to their own data. So it was purely for clinicians so that we could monitor the patient, see their compliance, and have a virtual telephone appointment. And then our other telemedicine arm that we looked at was actually the modem, but also giving the patient health access to their own treatment. So we used an app called Dream Mapper, which is a Philips app that comes with their device. And this allowed the patient to go and look at their own data. So their own daily use, what their mask fit was like. It also gives lots of motivational videos. The patients can set up their own kind of goals. So I would like to try and use my machine for this many hours over this week. So it was really to try and engage the patient in their own care and to take some responsibility really for their use. We also looked at some secondary outcomes such as apnea scores, Epworth scores, what their mask leaks were like. We also looked at, did this increase any ad hoc appointments these patients needed if they weren't coming to see us face-to-face? So we collected lots of data. We also wanted to have a little look at what the patient thought of this though. So this is quite unique within the study that we performed some qualitative data, and we took 5 patients from each arm and actually interviewed them to see what they thought of technology. Did it work for them? Did it not? Do they like virtual appointments? Because that was coming in quite rapidly due to COVID, just to get some really good feedback from our patients. So previously I'd looked at what the kind of studies were saying around technology, and there's a real mixed bag. So the Academy of Sleep Medicine absolutely emphasised we needed more studies. We need to look at this in greater depth because the outcomes in the studies that were available were very, very mixed. Half of the studies said, yeah, if you add telemedicine, compliance is much better in those groups. And half of the studies kind of said there was no difference. So we wanted to really re-explore this. Look, is there any evidence that using technology improves the patient outcomes? And we wanted to also look at our patient experience, which was really unique within this study. And by doing that, what we wanted to know was, should we be doing things differently? Should we be offering a technical virtual option rather than everybody coming in face-to-face to us? So this was the study guidance. So everybody came for their first appointment, whichever arm they were in. They were diagnosed with sleep apnea and they were appointed to CPAP. They were consented, should they be suitable for the study, and everybody's first appointment was exactly the same. So we standardized that. So everybody came in, they got fitted with their mask, they had an hour's worth of teaching and written information they took away with them. This then changed depending what arm you were in for all your follow-ups. So if you were in an arm with a modem or telemedicine, everything was then followed up virtually. So this was some of the outcomes from the compliance data that we've got. And this kind of said from my study that there was absolutely no difference whether you were seen via standard care or you received a modem or a modem and a health app. The thing about our study that we did find, though our patient groups were very similar that I've seen in other studies, 2 men to 1 female, body mass was increased, AHI was high. The thing that we did find is that in every arm, we had very high compliance, which is really unusual. So in our standard care arm and the telemedicine arm, the kind of average use was in the 6 hours, which is pretty good when you think how precarious compliance is. And then when we looked at that and compared it back to previous studies, that was one of the glaring differences in the studies that showed a significant improvement in compliance in telemedicine. Their compliance rate in standard arm was really, really low at 2 to 3 hours, which ours wasn't. So one of the reasons we may have no significant difference is just generally we'd hit the ceiling of treatment in all arms because they all did so well. But what he did show is actually there is no difference in the effectiveness of telemedicine when compared to standard care, which is a significance because that means we have an option. Everybody did as well. Their compliance was really good. So there was an option here to look at telemedicine as an alternative to those follow-up appointments. And that was quite important. So this is just some of the data, and this will be available later, that just shows that we had no difference in any of our groups. The demographics of the group were really similar, all similar ages. So yeah, there was not much difference in the hours they used their machine, the percentage of days they used. Each arm was exactly the same. So there was no significant difference in compliance data. So the conclusions that we found was, firstly, this study was quite unique because we compared just not telemedicine and standard care. We actually looked at 2 different types of telemedicine to see if that had an impact on patients' compliance. Is one method better than others? Our study was pretty representative in most studies that we see in these patient groups. We had 2 men to 1 female. Like I said, BMI was high, AHI was high, and this is very similar to what we've seen previously. What we did see, though, in our study was that we had high compliance in every arm, which, you know, was unusual when comparing to other studies and does question what are other studies doing as standard care. Is there something they're particularly doing that we're not, or we're doing something that they're not, and that's why their numbers are so low? And that's something we could possibly explore in the future to see where those stark differences are. It does open up the possibility of hybrid appointments because all of our patients pretty much did as well in each arm. So should we be offering a not one fits all, but a hybrid type appointment system for those patients who want it? Because some of the things that we're finding from the interviews that we've done is not all patients actually like virtual. Quite a lot of them like to see us. They like to come in. They liked that kind of relationship with their clinician and felt some of that was a little bit lost via virtual. Whereas some of our other patients who maybe work, are very busy, are more than happy to do an online, a telephone appointment and have disposable items sent out to them. And that suited them. So this is something I think we need to develop, is that we think about what works for one person and might not work for the next. So do we have some sort of system that allows the patient to pick? There are possibly some limitations to the study we did. As I said, I think maybe we hit the ceiling of treatment, hence why we had such high compliance in every arm. And it was difficult then to get a significant difference between the telemedicine arm and our arm. I made some assumptions when we powered the study based on previous studies about what we would expect to see as a positive difference in compliance, and therefore where our patients actually had such large compliance numbers in the standard care, it's possible that we slightly underpowered the study. And therefore, if I was going to repeat it, I may relook at that. This was a single centre study of a mainly white demographic. So again, it may not relate to every single population. There's very few studies in the UK, so it's quite difficult to compare our study to the others. Most of them were from America or Sweden, so that is another kind of thing to think about. What I really want to know is what is that difference in standard care and the impact on compliance? So what next? We've got to write up the patient experience results. And as I said, some people really didn't like the virtual route. So we need to think about how we use that. There is some more data from the study that we're going to analyse, looking at ad hoc appointments. Was there any difference in each arm in physiology time required? And we're going to look at developing a new pathway for virtual appointments for our patients. So I think the takeaway message was that telemedicine was no less effective than standard care, which is really good. It means our patients still do well, even on virtual. We have to think about a holistic approach tailored to the individual patients. We can't just assume that one thing works for everybody, because it doesn't, and that one size does not always fit all. And these are my references, and thank you for listening.
Thank you, Dr. Tracy Jones. Now for the question and answer session.
I ask a question from Carol. Is Carol online? Yes.
Yes, I'm here. Can you hear me?
Yes, Carol, thank you very much for that excellent talk. I was just wondering, in insomnia OSA patients, when you talked about treatment of insomnia, you spoke about CBT. What about the use of melatonin? I noticed that you also prescribed melatonin in your patient. What is your experience and how do you use it?
Look, I think a lot of patients are looking for something that we can do in the clinic. And I think if there is some issues where, over here, we have melatonin that's actually approved by our therapeutic goods committee, and we know it has melatonin in it. And we have extended the release preparation. So for those who can sleep but wake up and they have difficulty falling back asleep, sometimes I find it can be a sort of a helpful strategy to get them started. But ultimately, I think we all know that light is a much more potent zygiber, and that actually, it's one of the biggest stimulus that you can have to regulate body clock. And I think if the issue is to do with circadian rhythm and not having much light exposure, then I encourage them all to have a light exposure first thing in the morning and try to strengthen that circadian rhythm. If the main problem is psychosocial insomnia rather than having a circadian rhythm problem, I'm not so sure that giving them melatonin is going to be a simple fix that will resolve your insomnia. And I still firmly believe that CBTI is the way to go. And that will be supported by the practice guidelines from the American Society of Sleep Medicine.
Thank you, Carol. May I ask a question from Tracy? Tracy, thank you very much for that excellent talk. About virtual clinics, what is the cost effectiveness of having virtual sleep clinics?
So that is part of the next bit of data I'm going to look at to see if patients were seen virtually, did that trigger more follow-up appointments or ad hoc appointments, because we weren't seeing them face-to-face. But from a cost point of view, for just a normal follow-up appointment, obviously in the UK, we do get paid a tariff, depending if they're seen face-to-face or as a virtual. So it would change that tariff. So the income into the hospital would change. But actually, from our point of view, there isn't a huge difference in cost whether they come in or whether we do it over the phone, because the cost is really their disposable items and any products that they need on follow-ups. So it will be interesting to see whether that patient group required any extra ad hoc appointments, because that will be the thing that drives costs, I think, if they require to be seen more often, because we weren't seeing them in that face-to-face environment. But yeah, that is my next piece of work actually from the data, is to look at, did it increase or decrease the number of follow-ups these patients needed?
Thank you, Dr. Carol, Dr. Tracy, and Dr. Chandimani for valuable inputs in our symposium. Unfortunately, we will not be able to call Dr. Jason Ellis. So I am thanking all the speakers on behalf of Sri Lankan College of Pulmonologists. Thank you again. Hope we'll see the next session, all of you. Thank you.
Thank you.
Thank you, Chairperson and esteemed speakers. And now I invite the Chairperson to give the token of appreciation to our speaker, Dr. Chandimani Undugodage.